Welcome to another episode of the Dr. Geo Prostate Podcast. Today's guest is Dr. Arthur Bud Burnett, the Patrick C. Walsh Distinguished Professor of Urology at Johns Hopkins. He's world-renowned for his pioneering research in sexual medicine and prostate cancer, including discoveries that led to today's erectile dysfunction medications. Dr. Burnett has published over 400 papers, mentors future surgeons, and has received some of the highest honors in urology. In this episode, he joins Dr. Geo to discuss how AI and advanced nerve-sparing techniques are helping men preserve erections and continence after prostate cancer surgery. Let's get into it.
Before I proceed, I just want to clarify that this podcast and all Dr. Geo content is separate from my faculty position at NYU Langone Health. The views and opinions on this podcast are my own. Our guests and sponsors are curated by me and not affiliated with NYU Langone Health. Sponsors are a way for us to provide high quality information at no cost to you so that you can take better charge of your prostate health, testosterone, and erectile function, and also how to live better with age. Welcome to the Dr. Geo Prostate Podcast. I'm your host, Dr. Geo. Whereas my goal and intention, of course, to help you optimize your prostate health, sexual health, which is what we're going to talk about today, and everything related and connected. My guest today is Dr. Arthur Burnett. He's better known as Bud, and he is a world-renowned expert around sexual medicine and at one of the top institutions in the country at Johns Hopkins. You've probably heard him before. He's been with us, but I hate to say it now, it's been way over a year, maybe even 2 years already. The podcast is 3 years old. In any event, thanks a lot for being on again, Bud.
Well, thank you for welcoming me, and it's just an honor and a delight to spend a little time with you and be part of your podcast. It's my pleasure.
Thank you, Bud. For those that don't know you, you've been in the field for a little bit of time. You're a couple of years my senior, I would say. And you were in the very beginning of what's called as a diagnosis erectile dysfunction, where there's an ICD-9, ICD-10 code where we could say, yep, this is a disease and we can treat it. Take us back to those early days. Why? First of all, why? Who in their right mind was, you know what? I love urology, prostate. Oh, this is great. No, penis health, sexual dysfunction. This is what I'm going to focus on. And this is way before even Viagra, I have to assume. Take us back. What happened?
You're right. I've been here at Johns Hopkins about 40 years. And when I was training back in the 80s, I realized that this taboo subject, men's sexual health, everybody wanted to know about it, but nobody wanted to talk about it. And of course, I think us urologists need to take some responsibility in the area to really recognize the importance of that to men and really try to make some strides ahead. And back when I was training, of course, we use the term impotence. We evolved to the word erectile dysfunction. Impotence is such a negative term. It has a connotation of powerlessness and weakness and so forth. And I think we moved away from just a bad term. So know that. But I think just in terms of the general concept of things, back when I was training, you were right. Even in urology residency, we kind of poo-pooed sexual health in men. And we just said, well, if a man can't have sexual health, let's just, try to reassure him, maybe try a couple of the prescription meds that we're not sure how well they work. Himbine was a prescription I wrote a lot back then. And
Yohimbine from the yohimbe bark tree. Now, was it isolated, the yohimbine chemical? Or did they use yohimbe?
Well, you could prescribe it. I mean, it was formulated in pharmacies back then. And then, of course, I wrote for it. And we kind of understood that some men who had really had other health issues, and we can talk about this more and more here, that we recognize are associated with erectile dysfunction, it was not going to overcome diabetes and cardiovascular disease and bad health habits and this and that, smoking, what have you. But I was just told as a resident from my chief residents, well, if that guy comes back, I'm trying that. We'll give him penile prosthesis, and that's all we can offer. That's all we can offer to help man with sexual function issues. And we did have some sense that testosterone was involved back then, another subject matter. But helping men with erections where testosterone may have more to do with the sexual interest and desire and libido and all that. It really, we didn't have much to offer, and that was that. And so you're right. Back in that era of time, I really committed myself to the science of erection disorders, did some of the pioneer work surrounding a chemical called nitric oxide that had to do with how penile erections worked very much in a very rigorous, in the trenches level with scientists that I collaborated with in neuroscience here at Johns Hopkins, and we were able to figure out the science of penile erections, and that led as a foundation or had some sort of basis to help support these new medications that came along. You mentioned Viagra, and there's others now, and that was the start of a new frontier in our field.
Were you involved in the Viagra movement and the research with Pfizer at the time? I know that their intention had nothing to do with erectile dysfunction originally. By the way, I don't know if you know this, but you said you come to New York frequently. Yeah. Spike Lee is working on a Broadway show called Boner.
Okay.
And it's on the history of Viagra and the development of Viagra.
Well, maybe I need to go there and learn something. I don't know.
Or they should consult with you to learn about that history a little bit more deeply. So then, which is Viagra, was developed around 1990, was it? I just remember the commercials with baseball players and politicians.
There is quite a story behind that, and it's a bit humorous. Back then it was called UK 92480. And back when drugs are kind of in their development phases, they're all just given some numbers and letters and this and that. And Pfizer was working on this as a drug in a class that they thought would be helpful for heart issues. Angina, which is kind of chest pain because of poor cardiac circulation, as you know. And that they happened to be doing some of the early studies in the early 1990s looking at this for that purpose. And of course, as the story goes, many of the men who were participating in those clinical trials said, well, I don't know about my heart, but I feel like I'm getting some better erections. And they were reporting this. And then they kind of, in hindsight, looked at some of the scientific developments in erection studies that I contributed to, and some others as well, back in the early 1990s, that provided a foundation for this chemical process now that then gave credence to the role of these meds really having a role that could help the basic biology of how erections occur. And amazingly, that's how it kind of did a pivot and said, we're going to go in the erection field. And
and the rest is history. Wow. Talk about a revolutionary drug. It's amazing. So then, how about penile implants? You also have been and actually you mentioned that in the 80s, the options were yohimbine or penile implant. Sorry for my naivety here, but I didn't know that penile implants were even around in the 1980s. I should have known that. So what has changed as it relates to penile implants for, then versus now? Better technology, better equipment, better utilization of the patient. What has changed?
Well, you're right. The penile prosthetics have been around a long time. Frankly, there have been various kinds of materials, if you will, that have been used to try to create some form of penile rigidity. I mean, the original description was rib cartilage that was put in the penis that goes back with pioneer, right. That goes back several decades, really. And we won't go back that far with the discussion at the moment, but back in the 80s, they did have some fairly useful but primitive penile prosthetics. Surgeries were done whereby these devices were put inside the penis. And how have they evolved? Well, they have evolved because we have then, within the field, speaking collectively among many of my colleagues as well, contributed to how we've made these devices better. And these devices are not just simply, like a pipe cleaner surrounded by plastic and then just put it in the penis and there you go, you got something, Mr. Jones. But we've actually had now inflatable devices, which involve connections by tubing to hydraulic pumps and things of that sort. And they provide even a much more natural looking full erection when it's inflated. It can be brought to a deflate mode and look very natural in a flaccid look. And these kind of devices have been around now with the more modern devices, if you will, in the past 30 or more years, 30, 40 years. Now, where are we going next in the field? That's the exciting thing. And the exciting thing is, with advances in technology and even remote technology, there are going to be some ideas coming forward with automated devices that don't require that a man actually has to manipulate something in the genital area just to make it come up, but rather they can almost do a handheld remote, like your standard pocket phone or that sort of thing. And
there will be an app connected to
right, and it may be owned by a spouse, but not your girlfriend's. And
Right. No, honey, we need this down. Nope, not right now. Let me press this other button. Then there's a red button there for alert, help, help, like
But that's where
I love it. We'll talk about those things for sure. Are you still doing quite a few penile
Sure,
implants, bud?
sure. Yeah, I consider myself blessed to be an active surgeon as well as a surgeon scientist all these years to do a lot of things, but
Yeah.
still be involved with patients directly and see them in clinics and review their needs. And for those who do move on to consider penile prosthetic surgery, yes, I've done thousands of these kinds of surgeries and continue to do so.
I have to say, obviously, as a non-surgeon that I am, I think I've seen many patients. I see many patients after prostate cancer treatment, and those that get penile implants, it seems like the satisfaction rate is actually pretty high. I say actually, and I say it in such a way because you would think that, no, there's no way another surgical procedure, how good can it be? Is it worth the juice, the orange worth the
Yeah.
squeeze, as the
Oh.
saying goes? Um, but the satisfaction rate seems to be pretty high. Is that what you see
Sure,
as well?
sure, sure. I mean, and I think that's been well established, by surveys and things of that sort primarily. And the reason for that is that penile prosthetics, even in our current era now, do provide perhaps the best mode to achieve erections in a mostly spontaneous way, in a way that don't require planning and repetitive interventions that we still have to accept with the oral medications, even some of these other semi-intrusive but non-surgical options such as vacuum pumps and penile injections, which we can talk about. All these other options that are non-surgical to date still are just, I would consider them treatments that provide momentary abilities to engage in sexual activity, but don't really provide more of a corrective kind of intervention. Now, the penile prostheses, as we have them now, may be the closest to that because it's inside your body. You kind of had to go through a surgery, yes, but you have something that allows a lot of spontaneity, which is a big part of sexual activity for many. Guys, it's
Right.
like getting a new knee when you were sitting on the sidelines for a couple of years, and finally, yes, now you're back on the tennis court with everybody else, and you get fixed up. You got to get rebuilt, and then, but now you have an ability to still engage in sexual activity very spontaneously. Sensations are normal. Everything else about how it feels to a partner with sexual activity, all that's still normal. So it just provides an internal splint for the penis, but you can activate it and make it useful right away wherever you are.
So prostate cancer surgery, prostatectomies, the erectile dysfunction rate, I think, is higher than what surgeons say. And obviously, I know surgeons, urological surgeons, very well. Some of them I know very well, and these are colleagues that we have a great relationship. But I sometimes think, well, whatever they tell you in terms of what's the ED rate, maybe you want to bring that down by 20% or so. It's not quite as good. I remember one surgeon who will remain nameless. He says, "Oh no, my erection rates after surgery is 80, 85%, which is not possible, right?" So it's a problem, particularly for those that are interested in staying in the game, if you will. One of the things that surgeons do is they try to save the neurovascular bundle, which is very important for erections. Maybe you can expand on that. What's the neurovascular bundle and why is it so important to innervate the penis for erections? And B, what else can we do about it and what else is
Sure,
new?
absolutely. Well, with your preamble there, you certainly made an important point that I think, unfortunately, our field has been represented by too many literature reports and articles and even just the presentations at meetings that I think are a bit embellished. And sometimes this show what certain surgeons or surgical groups are attempting to say what their surgical prowess is without being entirely straightforward about really outcomes following prostate surgery and many other kinds of surgery we do in the pelvis that can lead to sexual dysfunctions. And so there's some reality to that. And I think we need to be more realistic, share with our patients the reality that carrying out pelvic surgeries does carry a risk because we know that some of the structures in the pelvis, deep in the pelvis, including nerves and blood vessels and structures leading to the base of the penis, is how erections occur. And that's deep inside the pelvis, and the prostate is right nearby that area. So surgery, as well as radiation now, and various other kinds of treatments for prostate cancer, even some of the focal therapies, can have some risk, and we just need to be straight about that. But I think that as we become straight, patients are more informed, will make better decisions, and understand what their outcomes will be, and then need to know how they may have to pursue other options or even treatments for erectile dysfunction, but also allowing us to make honest appraisals of how we got to do it better, and which is what you're leading up to. And what I would have to say with that is the neurovascular bundle, a term that kind of is thrown around a lot among surgeons, and perhaps even gotten some almost words in some of the literature that the general masses may pick up, suggests that there's this structure somehow in the pelvis that if we just save that, it surrounds the prostate, and it's just a simple thing. You save it and everything's going to be fine. Well, that is true, but it's more complex. The structure is almost a netting that surrounds the prostate that varies in different people. We need to know that it's not a simple little cable of nerves. It really is it's like a spider webbing that's hard to really preserve well. And even though we've done a better job to understand the basis of how these nerves, almost a network of nerves, feed the root of the penis deep in the pelvis, it's a complex matter. And surgically trying to do our best dissections to remove the prostate from the middle of that, like taking out an onion, leaving a surrounding layers and so forth, is not an easy feat. And
That sounds difficult, Bud. And again, I'm talking from a non-surgical perspective that I am, right? I'm not a surgeon, but I've looked at the anatomy and I'm like, how can you tell that this is it? This is the neuro, because yeah, when you look at an anatomy book, everything is in nice colors, right? So the prostate is this, the blood vessels are red and the blue veins are blue. And you see the arteries are the nerves in yellow. In real life, these things look very all similar to each other. So one, identifying it, I don't think certainly for a layman is an easy task, but I guess you become better at it. And then that peeling, isn't it like tightly stuck, the neurovascular bundle tightly stuck to the prostate, which then makes that peeling process a little bit, a challenging thing to do. And perhaps you can actually damage that bundle. I'm just
you're absolutely right, and you're describing it, as you say, fairly well for somebody who's not doing this surgery. I've done a few thousand of these operations, so I could say you're right. It's technically a demanding thing to do, and you're absolutely right. It's these nerves are encased in some layers. We call it fascia, which look like almost like layers of an onion, and these nerves are as fine as angel hair. And really trying to say, okay, where are these nerves going? And all of them kind of coalesce in a way that they kind of feed the root of the penis on each side, because the penis kind of has bilateral structures to how the penis is structured in the pelvis. There's two sides that come together and making one penis structure. But deep in the pelvis, how do these nerves find their way there? How do we dissect them off the prostate? Finding the right layer to gently lift them off, pull the prostate out. I don't want to sound over dramatic, but really that's kind of how you have to do it. And it's not an easy thing. And I think where we're going next, frankly, is how can we map these nerves better, case by case, patient by patient, bring this precision mode, not just to medicine, but surgery. And we're bringing forward new technologies that may allow us to do that dissection better.
Yeah, and you're referring to intraoperative neuromonitoring, which we were talking about before we started recording. And at the AUA, you informed me about it. And in my mind, I'm thinking, oh, there he goes again. Innovation, looking at things differently. How can we make things better? This is the Bud Burnett I know. So I was excited to talk to you about it because I know nothing about it. So go ahead so this is a different approach, as I remember having this conversation with you, in men while undergoing a prostatectomy. You're trying to be more personalized in the approach.
Absolutely.
What are the differences that we're looking at? Isn't it a neurovascular bundle and for everyone? What differences are we looking for? You've been taking care of your health, regular checkups, staying active, trying to do all the right things, but lately you've noticed something's changed. Maybe you've more tired than usual, your motivation dropped, or your strength and stamina just aren't what they used to be. These all can be signs of low testosterone, a condition that affects nearly 1 in 3 men in the United States. Kaisertrex is an FDA-approved oral testosterone replacement therapy that helps restore testosterone levels back to normal. It's not an injection or a messy gel, just a simple twice daily pill that fits easily into your routine. Find out where you stand. Order a testing kit today at kaisertrex.com/testing-kit, or look at the link below in the show notes. By prescription only, Kaisertrex is a controlled substance and can be a target of abuse. Kaisertrex is not for use in pregnant women or men with prostate or breast cancer. Safety and efficacy in those younger than 18 is not known. Tell your doctor about all medications and conditions. Serious side effects could include increased blood pressure, worsening prostate problems, increased risk of prostate cancer, blood clots in legs or lungs, liver problems, enlarged or painful breasts, and breathing problems while you sleep. Common side effects include swelling of the ankles, feet, or body, increased red blood cell count, and increased PSA levels. PSA is a test used to detect prostate cancer. Report these symptoms to your doctor. Call your doctors to learn more about Kaisertrex. For questions or information, visit www.kaisertrex.com or call 1-833-949-5040. What exists?
Well, I think the reality is that, again, and as in all of our bodies, things are basically the same, but there's a lot of differences. You can, the men are tall and short and wide and thin. You can look at any part of a person and say they're not exactly the same. Inside our bodies, things are even more variable than people might think. And speaking as a surgeon,
some prostates have a bigger right lobe than a left lobe. They're not equal or evenly proportioned, and they kind of some look more longer than others. So
there's a lot of variability in everybody's body shapes, and internally structures are, we know where the prostate is, but you can line up 10 different guys and it could be different shapes, different kind of kind of way that blood vessels and nerves encase it. And so you're right, this is a la precision medicine or personalized medicine these days. We recognize that we need to take our surgical abilities to a higher level. And this idea of intraoperative neuromonitoring, I've been working on for 10 years or more. We've recognized this as a kind of an innovation in a way to urology, whereas it's been really something that's been brought to neurosurgeries and spine surgeries and orthopedic surgeries for years. And they've got a lead start on us in these other disciplines, because it's just the idea here that the surrounding structures do preserve functions. And we have to do our best not to violate these other structures that provide functions that are neighboring tissues and neighboring organs and things of that sort. If you do spine surgery, you don't want to just take out a kind of some sort of spine mass or a vertebra that's somehow fused or got tight or this or that, but then leave somebody paralyzed. So, I mean, obviously, we won't tolerate that, and we got to do that better for spine surgery. We need to have the same kind of mandate in pelvic surgeries. And I think we're now proceeding forward with ways where, even though there is a lot of intricacies, a lot of difficulties doing this, finding the right kind of way of generating nerve signals, right kind of way of picking up the response, mapping these nerves that are variable in each person. These things have been the challenges we've had to try and move forward with, but we're conquering some of these things. And we are now doing some pioneering studies, pilot studies here at Johns Hopkins when men are undergoing radical prostatectomies, whereby we can actually map these nerves and do a better job of preserving them. We're going to study our outcomes that may still be years in the making, because the reality is recovering after prostate cancer surgeries is not something you just assess 2 weeks later. You got to assess patients over a couple of years and see how well they regain function, preserve functions, and so forth. But this is kind of the new direction we've got to bring forward.
So expand on that with a little bit more detail. What is it exactly that you're doing? Are you in the operating room along with the surgeon who's removing the prostate to make this happen? What is the process
Absolutely.
like?
So you're right. I'm glad you asked that. As we go through our discussion, let me drill down a little bit more for everybody's understanding. So this is actually a procedure that is combined with the surgery itself. And so after the patient has been brought in the operating room, has been induced by anesthesia, is being kind of positioned in a certain way to go about an operation on that patient, respectfully with that person's body being positioned in certain ways. And then we start the operation. We apply various kinds of sensors and probes and things like that in the area of the surgical dissection and monitor the effects as we're carrying out the operation. The surgery is done by myself or one of the other surgeons. We have some technicians working alongside us that are trained and have a special role with different aspects of helping us monitor, because they're off to the side. They're not really in the surgical field, but they can do this sort of monitoring, almost like the anesthesiologist in the operating room, having their monitoring equipment adjacent to the operative stage, but they're not really right in the operation directly with the patient.
But let me ask you, before you continue, let me ask you another question just for clarity purposes. I guess what I'm asking is, the surgeon who's removing the prostate, who's doing the prostatectomy, are you in there with that surgeon as well to do what you do for this intraoperative neuromonitoring?
So I personally have been a mentor with some of my other surgery colleagues, because the original surgeries in this mode, I have been the surgeon, and then
doing the prostatectomy.
prostatectomy.
Okay, sorry. So I just pigeonholed you. You know, silly me. I forget, of course, that of course you've done prostatectomies. To me, you do implants and deal with ED, but of course you do prostatectomies. So you're doing the prostatectomy, and also doing during this process you're doing this intraoperative neuromonitoring as well.
But I've got some assistants now, and I've and others who are with me. Of course, I have an assistant who's helping me with the operation directly. That may be one of my residents or a fellow. But as far as specialized things, we've got some special technicians playing roles, not standing right beside the patient, but adjacent in the operating room. And once I've kind of now moved forward how we're doing these surgeries, I'm now rolling it out to some of my colleagues where I can actually not have to be in the operating room. And frankly, this is going to be the future. I can't be doing watching everybody's surgery across America for the next 50 years. So I'm just trying to get the technique down and demonstrate it, and then really operationalize a protocol, if you will. And then the technicians will be trained, and then surgeons can independently apply the technology as they carry out the operation.
Beautiful. All right. So I just want to make sure again that I understand and the audience understands. So the prepping for the prostatectomy is no different than any other prep.
It is the same,
except that
and all these technological kind of tools and sensors and probes, that just adds another just 15, 20 minutes in the midst of doing a 2-hour operation. It's still very efficient. It doesn't prolong the operation in any kind of substantial. And the whole operation is just carried out almost in the same fashion as if we weren't bringing these tools, these
right.
But these little things we do just apply in the area of the surgery, and it's just really minutes of time, not hours of time, that adds to the surgery.
And so where are these probes located again?
Well, I can drill down even further for the audience. We have now actually pioneered ways of doing intraoperative erections. Or not. We have pioneered ways in which we can do this. There have been ideas that go back a couple decades with some handheld probes in the pelvis that didn't really work well. We've actually developed a technique now where we can put various kind of temporary spinal electrodes. So actually, after the man has been induced under anesthesia, we can turn him to the side, place these little probes through the skin right toward the bony parts of the vertebrae, or at the low part of the back, and then just tape them down on that patient's body, and then turn the patient back to kind of a more lying down, looking toward the ceiling position, supine, and then just start the operation. And believe it or not, we have, through wiring and so forth, from those spinal electrodes to the side, we can actually do kind of stimulation, which brings about erections intraoperatively, because we can stimulate the nerve roots that run to the pelvis. And that tells us now, while we're doing the operation, that erections are happening. And then as we execute the operation, we have various little instruments deep in the pelvis that can pick up the nerve signals, where we can pick up exactly what are the nerve projections and the routes of the nerves that may vary man to man, and then know which nerves we should be avoiding. And we can actually real time and continuously know which nerves may be irritated or changed as we start the dissection, and modify some of the aspects of the surgical technique as we do it, so that we in real time are preserving that man's erections.
So you're communicating with the surgeon that's performing the prostatectomy?
Absolutely. So
in real time.
Right. So now the early stages of our procedure, much like all science, things are not instantaneous. We're now we're just making sure we're mapping things well. We're actually recording with machine learning, AI, which is a big buzzword these days, recording these surgeries so that we can actually show exactly how the dissection can be recorded and understand the various kinds of irritations and various moves with the surgery that can tell us where nerves are being traumatized. Okay, and with the intentional development of this here over the next several months, we expect that within a year or two, the machine, case by case, will tell the surgeon intraoperatively, based on auditory signals like a beep, 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 or a light flashing, oh, you're getting close to these nerves. And we will have techniques where the surgeon can immediately then make adjustments. So we're at a stage right now where we're just trying to record things well and understand how these nerves are being irritated and train the system, the machine learning, to develop these algorithms, if you will, these various kinds of protocols whereby we'll know what the dissection can impact the nerves and how that can inform the surgeon. But the next step of this here is we're going to have ways in which the surgeon will be informed and modify the operation.
Wow. That's so. Is this AI technology?
It is a technology where we've got working within a group now. So some of these things involve experts that are in their respective areas of expertise. I mean, it's myself as a surgeon and a scientist, and maybe the pioneer and the visionary. But I also had to have some neuroscientists involved, some technicians involved, some AI specialists involved, and programmers involved. So it's a team effort here.
All right. So during the procedure, you put in these probes and you can actually stimulate an erection while this person is under anesthesia to just ensure that these are the right
Exactly.
nerves.
So, and that's been a key aspect to this, because one of the challenges, again, as I mentioned, that the others have had these ideas too. I don't want to say nobody else has thought about this over the past couple of decades, but nobody's really been able to really achieve a reliable technique of doing this intraoperatively. And we've kind of now mastered that now with a technique that we have investigated, developed, and now are using it within our surgeries. And so that's one major step to allowing us to be able to map the nerves. You got to be able to have a stimulus that reliably can help us determine where the nerves are and what nerves are relevant for erection. Because a lot of nerves, as you say, coursing all out the pelvis, we got to understand which are the ones that just may go to the sidewalls of the pelvis, go, here and there, and may have something to do with bladder function or this or that. Now, of course, we want to preserve all these nerves and do the surgery well. But if we're really trying to do our very best with sexual function recovery, we want to identify the nerves that are really relevant to penile erection.
So once you identify these nerves while the patient is undergoing their prostatectomy, as the surgeon gets closer to those nerves, it'll create an auditory sound where it says, okay, you're getting too close. And then he'll have a different approach or technique.
Absolutely. So that's exactly the purpose. And, ultimately, we can get into further discussion about why this is so important. But I think that any man who's going to go through a radical prostatectomy is going to say, if you could preserve my nerves better and you can do it in a reliable way, and it's not going to really have any side effects or change the best performance of the operation, we want guys to be able to have that opportunity to have that.
I guess my question is, why are we doing this? Why are you doing this? We're already preserving the nerves. Isn't that good?
Well,
enough?
Good point. And yes, through one of my mentors here at Johns Hopkins, Dr. Patrick Walsh, that many urologists know by name, he was able to recognize that preserving the nerves based on basic anatomical principles was key, and described some of that back in the mid to late 1980s. And that really advanced the whole field of radical prostatectomy back then, because the prior era was all men just knew that if you went through a prostate cancer surgery, you had to accept that you'll never get natural erections ever again. Well, that was changed. And many men, just by doing the surgery well, understanding the basic principles of nerve dissection, many men were recovering function. But our field has been fairly stagnant now the past 30 years, because just following the principles alone is not good enough. It's not good enough. And while there's been varying rates, as we earlier said, between investigator groups saying, I get these kind of recoveries, I get that kind of recoveries, notwithstanding men may not have had those kind of erections to begin with going into the operation, because some may have other health issues that impacted their sexual function. But notwithstanding all of that, another discussion point, but notwithstanding that, the reality is we have not seen much further improvement now in the past 30 years. We just see maybe an average amount of guys getting erections back. And I think the real answer for not seeing better improvement is the neuroanatomical or anatomical principles alone are not good enough. They're not good enough. We need to recognize that each man's nerve anatomy can be variable enough, and we need to, as surgeons, be guided intraoperatively better, okay, about what we do. We have GPS systems in our car nowadays. So if you go on a trip here or there, you may remember the route. Maybe you didn't. Maybe you went off another roadway. Maybe you spent an extra half hour traveling in the wrong direction, but you still got there. Okay, but it's not good enough to say we all just got there. We all got to go by the best route to get there every time and every man. And that's what we got to do.
Yeah, I love GPS. I can't believe that I lived a whole life without it for so long. I mean, I would go to a place that I regularly go to, and I will still put the GPS on just because I just don't want to think of, I remember turn left or right. I want my mind to be somewhere else. So I got lost so many times prior to I just, one of the best inventions of all time is the GPS.
I hope analogy, because I mean, you still found your way. You
still found your way, but it took too long. And I got lost many times and I couldn't think of other things, right? So it wasn't as efficient. You're saying this is more targeted, more efficient, and produce better results. So you're also saying or implying that even when there's preservation or nerve sparing techniques, the ED rates are still relatively high.
The ED rates are relatively high, and and our erection recovery rates need to be a whole lot better. They're not good enough. And I think the reality is because we can pat ourselves on the back and say we're great surgeons, but we're all humans doing these operations, and as talented as any one of us are and as experienced as any one of us are, we still can benefit from having some additional guidance while we do these surgeries.
So what's the follow-up? So the patient gets the surgery, you do this technique, we know the nerves that in this particular patient innervates the penis and helps them with the erections. They get the surgery done. Then what? Is there a follow-up to that? Is there something that's, a drug or an approach that makes sure that this particular nerve is continuously stimulated whenever he wants to be functional? Or is that it?
Well, I think that's essentially, it's more the latter. We do the surgeries better in such a way that we predispose, or at least gear that man up to have the best opportunity to recover his erections better, because the nerve integrity is better preserved. And then recover normally with any prostate cancer surgery. But we just hope that now that man has a better preservation of nerves, and that the structures that are relevant to gauging the blood vessel circulation in the penis and causing erections, these nerves regulate erection deep in the pelvis. And if we can actually just make sure that man by man, person by person, that person has better nerve preservation, that they'll be better predisposed to recover their functions.
We oftentimes say that if you are, let's say, in a scale of 1 to 10, 10 being erections are amazing before surgery, 1 being that is 0. And if you're, less than a 5 or 6, it's not going to get better after surgery. Is there any remote possibility that from this approach, they go from a 5 to a 7 or 8 after the surgery? Does it get better? Can it get better after surgery? Is there any remote possibility?
Well, now you open up another whole subject area for discussion, because we're talking about nerve regeneration and how can we recover these nerves, really, which is ultimately kind of getting back to the conversation before, that our treatments, to at least to where we are today, are just momentary interventions. And if we can figure out new therapies that can help recover function and improve from a baseline level, that is the next frontier too. So really there is great interest in nerve protection, nerve regeneration. Can we do this with this technique? I don't think the technique alone is going to make anybody better. It's more a matter here of not having them lose more function. But we do have some ideas going on in my group about
nerve. I can imagine.
Nerve regeneration. In fact, we're doing another trial, which I can just briefly mention, involving putting it in the pelvis at the time of surgery, in addition to just doing the surgery better, which is what kind of the goal of this neuromodulatory intervention is all about. But we're actually have a trial going on with a study I've also been doing for the past several years with implantable electrodes in the pelvis that can be done at the time of surgery. They're almost like little tiny postage stamps, and we can actually program those to actually help the nerves just heal up faster and maybe even regenerate. And we're studying that as another kind of approach to enhancing function and bringing it to a higher level, possibly in some men who are having some nerve trauma. And in fact, there may be some excitement with various kinds of pelvic surgeries, spinal injuries, and so forth, that these kinds of techniques also may make nerves kind of come back and heal and then be more functional. So we have ideas in that arena as well. We're working on that too.
Sounds good. Wow, but thank you so much. So when do we expect this, assuming that the research works out as well as you think it does, when will patients have the possibility of opting for this? And I guess, everything takes time. So even after it's approved, after it works, then it just takes time for it to be accessible, because then you need to train other surgeons to do this approach. But let's just say people are willing to go to Hopkins once this is done. How long do you expect before this is available for people?
Yeah, so in terms of a widely available approach, I think that's still going to be a couple of years off. As you alluding to has got to go through regulatory approvals, FDA approvals, certain level of trials beyond just the pilot site, which is here at Johns Hopkins. We have to do multi-institutional trials that may take 2 years or more to do. So I would say, expect within 5 years it's going to be widely available, but it's not going to be next year. But if patients are very interested in this, I guess I'll take the liberty of saying, since I'm on your podcast, come to Hopkins. We're doing these trials right now, and you can be involved in this if you think you're interested in hearing this.
So if they want to be part of the trial, there's a way to do that. How can they learn more about the trial and even about you?
Well, just the quick answer is I'm at Johns Hopkins. I've been fortunate to be here many years, and I think we're pretty well known on the map here. You can look up my name on websites. I've had people contact me from around the country, around the world all the time. And through my assistants and whatnot, we'll receive messaging and get you to my study coordinators and further determine whether coming here is something we can offer and help with your involvement, and maybe further discussion whether you want to be involved in a trial. If you're having prostate cancer and it's been recently diagnosed and you're thinking, well, surgery is going to be something I'm going to have to think about, well, get a hold of us. Get a hold of us. We're glad to hear from you.
Maybe there's a link or something, but that you can share, and I'll put it on my show notes.
Yeah, we can follow up on that. Yeah.
Great. Dr. Arthur Bud Burnett, one of the best, been in the field for a long time, 4 decades, and a lot of experience and published tons, and really one of the go-to guys for ED and male sexual health. But thank you so much for being on. Always a pleasure to speak with you and connect with you. And I hope to see you again.
Geo, it's been my honor, my delight. Always fun to interact with you. My pleasure.
Thank you. Thank you, everyone, for watching this episode on erectile functioning after prostatectomy. What's new? What's new in the pipeline? Well, this is it right here with one of the best. Thank you so much for listening. And always remember, after prostate cancer, be a thriver, not just a survivor. And lifestyle medicine, lifestyle approaches matters. Dr. Geo here, signing off. Much love. Talk to you next time. All the best.
We hope you enjoyed this episode. You'll continue to receive powerful interviews and insights to support your prostate health journey. For those who want to dive deeper, our exclusive membership offers even more.
If you love what you heard today, you can help by leaving a 5-star review of the podcast on Apple and Spotify, as each review helps us reach more men who are serious about improving their urological health and how to function better with age. And for the latest research and actionable takeaways in the world of men's health and integrative urology, sign up for my newsletter at drgeo.com. I'll see you next time.